Hello, and thank you everybody for your time today. I'm here to talk about video laryngoscopy at the roadside and airway management in challenging environments, which as a pre-hospital practitioner is something we often encounter. So I'm Peter Edwards, and I'm a critical care paramedic working for West Midlands Ambulance Service and the Midlands Air Ambulance Charity. So I work on a variety of platforms for both the ambulance service and the air ambulance charity. And my colleague, who is also going to be talking to you today, is Dr. Ben Taylor. And he's a military consultant anaesthetist, and he's based at the Royal Stoke University Hospital. And he also works on the merit platforms, such as myself, with West Midlands Ambulance Service and Midlands Air Ambulance Charity, and also the Air Ambulance Charity. So both myself and Ben work in a variety of roles, and one of them is the merit team, and that is the Medical Emergency Response Incident Team. And this is a doctor-led team and that works alongside a critical care paramedic. So that is a paramedic that has an extended skill set over the standard land ambulance. And some of those, that involves some extra skills such as advanced analgesia, paralysis, sedation, pacing, intubation, and some surgical skills. And this is a commissioned service that is trying to get the right skill set to the patient rather than having to try and get the patient to the right skill set. So we're trying to get a advanced critical care team to the patient as fast as we can, wherever that may be across the region in the West Midlands. Primarily, the merit team is targeted to major trauma cases, but we're also aimed to respond to patients who are critically ill, such as those in cardiac arrest or those who've suffered heart attacks or strokes, and that the patients that need the interventions that can be provided by a critical care team, and that's what merit provides. We're a 24-hour-a-day service, and we operate every day of the year, and we have two platforms. One is a helicopter, which is provided by Midlands Air Ambulance Charity, and we are based out of RAF Cosford, and that operates from 7 in the morning until 7 in the evening. And obviously that is dependent on daylight hours. And then once it becomes the evening, at 7 o'clock in the evening, we switch on to a car-based system, and that is on a rapid response vehicle that is located in the near to Birmingham in Albury. So another platform that I work on in particular is the critical care car, which is a charity funded car, and it is most often it'll be a solo critical care paramedic such as myself, and we're responding around the Birmingham area, and we're mainly targeted at medical cases or patients that again that are critically unwell due to usually it's medical cases such as cardiac arrests and again heart attacks, sepsis patients, unconscious patients, asthma patients. We carry extra drugs and equipment for those sort of cases, but we will also respond to major trauma, and we often respond alongside our colleagues. We will be dispatched to the job by car. We may get to scene first, and then we'll be backed up if needed by the HEMS team, the helicopter team, and we can start preparing a patient or optimising them ready for when the doctor and the CCP on the aircraft arrive at scene. And again, the critical care car and the critical care paramedics that work on it, we have an advanced skill set, and we are autonomous. And one of those skills that we perform is intubation. So if I could just talk a little bit about paramedic intubation and a little bit of the history of it. So up until recently, paramedics working on land ambulances did have intubation as a skill set, but that has recently been taken away from their practice. And that's come to light really due to a number of reasons, including lack of exposure to patients that need intubating, and that lack of exposure has meant that they're impossible, that they can't get the number of intubations required to remain competent at it. And unfortunately, despite the introduction of waveform end tidal monitoring and the mandated use of bougies in the pre-hospital setting, there has been a number of incidents where there's been unrecognised esophageal intubation within the West Midlands Ambulance Service region. So that has led now to only specialist teams, such as the ones that I work in, the critical care paramedic sort of teams and the doctor-led teams, that they're the only ones now that within the West Midlands Ambulance Service and other ambulance services it's happened to as well, where standard paramedics no longer intubate. But even for those of us who work in these specialised teams, we do have to maintain a required level, a required minimum number of intubations per year in our logbook, and we have to go into theatres to get these numbers sometimes, and we work alongside anaesthetists in theatre to practice intubating, and also the doctors that we work with on pre-hospitally. Also, we have a lot of direct observation of our practice of intubation. I think
I'm going to jump in here and just explain why intubation in a pre-hospital environment is much more challenging than you might expect to find it in hospital. It's often, first of all, in a difficult environment, often very far, often the polar opposite from what you expect in your anaesthetic rooms. You're at the roadside. It can be a variety of weather conditions. It can be dark at night time, often in confined spaces. You can have people wandering through scene, threats to yourself from vehicles and a live carriageway, and from other risks as well. Your patients, almost by definition, are unfasted and unprepared. So they're having an intubation as an emergency procedure as part of their stabilisation, rather than to prepare them for an anaesthetic to facilitate surgery. They're having an intubation for a reason, usually a severe head injury or other injuries that require ventilatory support. The equipment is limited to what you can carry in your bags on your aircraft or in your car. So you cannot have a full difficult airway trolley because you're limited in the kit and equipment that you have available. And you're working alongside, as part of a small team, working alongside ambulance crews who, as Pete's just said, are becoming less and less familiar with intubation, the risks, the benefits, and the required steps as part of that procedure. There's a recognised high risk of complications in the pre-hospital environment in terms of, as we said, failed intubation, unrecognised esophageal intubation, and because of the patient population, you're dealing with aspiration, desaturation, and often trauma to the head and neck, which can occasionally make intubation a little bit more difficult. On scene, there are multiple concurrent tasks that need to be carried out. We need to take our kit out of the bags, out of the sterile and clean packets in a dirty environment. So there is time. For a time critical procedure, we need to take the time to prepare our kit and equipment, our drugs, our medications, and we need to optimise our patients as best we can before starting the anaesthetic. For example, somebody who's in hypovolemic shock from other injuries, we need to restore their volume burst by giving blood and blood products. And we'll need to look at optimizing their position and moving them, extricating them from potentially hazardous areas before we start. Given the small team of usually 2 clinicians, we will divide teams up to make things more efficient and safe as possible. Given that, we usually have a split between the first look intubator, who's going to be very task focused on that single task, and someone else with situational awareness who can manage the rest of the anaesthetic. Normally in our teams, we'll have the critical care paramedic having the first look, while the critical care doctor will manage the remainder of the anaesthetic. However, for example, if you've got a case where you've got a high likelihood of a difficulty airway on your initial assessment, that we may swap roles. We may actually manage things the other way around and have the doctor having the first look at the airway. As a team, we work very closely together. We need to have trust and confidence in each other. We need to know our abilities, our limits. Involves often having a chat throughout the day, making sure that there's nothing else going on outside of work that's going to affect what we call our CRM. And we'll look out for each other and make sure we spot problems that the other person may not have spotted. We also make sure the patient safety comes first, and we only do the intubation, these procedures, if it's absolutely definitely required. And as I said, if there's a predicted difficulty airway, for example, someone with severe head and neck trauma, we'll also have the most experienced intubator having the first look for that individual patient.
I'd like to share with you a case study from March 2020 that forms the basis of this presentation. And it was when I was working on the critical care car in Birmingham, and on the day, obviously I was solo, as that platform generally is. And then Ben was working on Helimed 03 from RAF Cosford. So quite early on in the morning, we were called out to a motorcyclist who was reported to be unconscious after colliding with a car. So I made my way to scene and arrived to find a young man with an obvious head injury. He'd driven his motorcycle, or we're not exactly sure the exact ins and outs of it, but he collided with the back of the car and sustained a significant head injury. And on my arrival, he had a reduced GCS and was actually very difficult to manage because he's very, very agitated and combative. So he was bleeding from the head and the nose. It was a difficult case, and quite early on, it was apparent that he would need an RSI. And my role in that case was obviously to start prepping the patient, ready for an RSI, ready for when Ben and Ryan arrive on scene, and to try and speed things up so it would all be seamless. And on their arrival, we could get on with giving an anaesthetic. So Ben and Ryan backed me up. And when we realised that this patient, after having a team chat, we decided, yes, that is the appropriate thing. He needs an RSI. We then went on to discuss how we were going to approach it, who was going to be the intubator and the team leader. And we decided I would be the intubator on this occasion, with Ben, the doctor, doing the drugs and the general overall team lead. And Ryan, the second CCP, would assist me with the airway. And we decided that on this occasion, we would use the video laryngoscope. So when we did come to intubate this patient, and we shall show you shortly, that he did have a blood-filled airway, which made things very difficult. It was difficult to get a view of the airway or the vocal cords using the laryngoscope in the traditional form. So we eventually switched to the screen and used the video laryngoscope, and we actually managed to pass the tube on one attempt. So the next clip is a video that featured on a program that aired on Channel 5 called Ambulance Code Red. And they were out filming with us as part of their series that was shown last year. And they've allowed us to use the footage. And here is a short snippet of the case that shows the intubation.
29 minutes after the 999 call, the Midlands Air Ambulance arrives with critical care paramedic Ryan James and trauma doctor Ben Taylor.
He's collided with that car, or the car's collided with him. It's thrown him off, his helmet's come off in the impact. He's got a big head injury.
To place Curtis into a coma, he first requires RSI, rapid sequence induction, an advanced critical care respiration procedure that Pete decides is safest to do outside the ambulance.
Because the process is quite risky, we need to have 360-degree access. So if the patient starts to deteriorate for any reason, or we're having difficulty with the airway, we've got good access and we're not sort of fighting over each other.
Dr. Ben then prepares to put Curtis into a coma with 2 injections, a sedative and a paralysing agent.
BVM.
Yeah, on.
End-tidal.
End-tidal's on, reading at 3.0.
BP systolic.
The last systolic was 127.
And cycle set.
Cycle set every 3 minutes, automatic.
Saturations. Okay, drugs going in now. Okay, fentanyl's in. Ketamine is in.
Okay, everybody ready? Okay, so oxygen mask is coming off. Okay, there's no loose teeth that we've seen. So I've got the blade and I'm going to open his mouth as wide as I can.
We're going to go for the video
so
scope
we've got
first.
Video scope first, with a size 4 blade.
Mm-hmm.
Okay, we've got a backup of a Mach 4.
Yeah.
Batteries check charging.
Okay.
A laryngoscope, a camera with a screen, allows Pete to look into Curtis's airway for obstructions.
I'm going down the right-hand side of his mouth, sweeping the tongue to the left, and I'm going to walk down as I go and looking for landmarks. I've got the epiglottis, but... Okay, a bit of suction, please.
Suction.
There's quite a lot of phlegm at the back of his throat.
Okay. What would you like?
Okay, I've got a grade 1 view there, I can see the cords.
With a clear path, the breathing tube can be inserted into the trachea.
Okay, I think through the cords and the black line, we are 22 at the teeth, Ben. Okay, we've got misting of the tube. Okay, I'm coming out with the blade. Cheers, thanks.
Curtis is now in an induced coma and breathing with the aid of a ventilator.
I would just like to say that the patient involved on this case has consented to the footage being used, and that footage was shown on national television, and is a useful video to show sort of some of the difficulties we do face pre-hospitally, and why the video laryngoscope or video laryngoscopes in the pre-hospital setting definitely add value or have a value. And this first still image just sort of, it's sort of highlighting some of this patient didn't go out of the house in the morning expecting to have an anaesthetic that day. He's got a beard. We can see he's got a beard. He's got quite a long neck. You can see from the my gloves while I'm doing a jaw thrust that there's blood everywhere, and like I said earlier, including in his airway, which adds to the complexity of this case and pre-hospital RSI in general. So some of these stills, again, taken from the video, you can quite clearly see that we're using a video laryngoscope. You can see some other members of the team there, including somebody. It looks like they're on the phone, but they're actually doing the timings for when we were doing the drug administration and the for when drugs are administered, just to take a little bit of a task away from us as a team. We get somebody else to do the timings, and that just gives us a little bit of extra bandwidth. You can see there that in the first instance, I'm using the video laryngoscope as a traditional laryngoscope and trying to get a view through the oropharynx. And when I have got the blade in, there's a lot of blood in the back of the airway, so I'm having to suction to try and get a view. And then after I've suctioned, I was still having difficulty. So what we decided was that I'd switch to using this device actually as a video laryngoscope. And at that point, I was able to visualize the cords. I used a bougie and passed that through the cords, which is, like Ben said, is standard in our procedure. And then the patient was successfully intubated, put onto the ventilator, and then we finished packaging him, ready for transportation to the major trauma centre.
So video laryngoscopes are widely used in hospital, and we've recently started using them in our pre-hospital role as well. The benefit, we feel they've got lots of benefits in certain circumstances, in particular the types of laryngoscope that can be used as both a normal direct laryngoscope and a video laryngoscope as well. So they have the number of issues they help with are, first of all, potentially difficult intubations with abnormal anatomy. After all, anyone who might be in hospital difficult intubation could also get involved in the car crash as well, and potentially might need a pre-hospital intubation. There's some evidence we'll come on to a second that they may make them give you fewer attempts and a shorter duration of laryngoscopy, which might reduce any issues with intracranial pressure, potentially with brain injuries, which are probably a most common reason for pre-hospital intubation. They reduce the risk of, if you can reduce the risk of prolonged intubation or laryngoscopy attempts, you reduce the risk of oxygen desaturation as well. And as we'll come on to in a minute, in certain conditions, it may reduce the risk of failed intubation. With our patient population, there's also a risk of injury to the cervical spine. So with the video scope, we potentially require less movement of the head and neck, which might reduce the risk of causing a secondary spinal injury. As I said, some patients, you may have a potentially difficult intubation for other reasons, for example, anatomy, previous head and neck radiotherapy, and you can use hyperangulated blades to get a view where you would not otherwise be able to get a view with a traditional laryngoscope. And finally, given the context of paramedic intubation, which Pete mentioned earlier, it means that we can supervise and help mentor our paramedic colleagues as they develop and maintain their skills in relatively straightforward intubations. So there's this one, because we can see on the screen their view and then give them direct feedback if required. As you'll all be aware, availability of a video laryngoscope is a recommendation from the Difficult Area Society and the Royal College of Anaesthetists when intubating all critically ill patients, which our patient population generally would count as. So in addition to the benefits of video laryngoscopy that Pete's just mentioned, there are some unique limitations in the pre-hospital setting that we have to mitigate and encounter. So one of the main examples is bright sunlight. And on a sunny day, we can make the screen difficult to see, and we mitigate that by using people to screen the sunlight, positioning the patient out of the way of beams of sun, even getting the firefighters to hold up a tarpaulin or a screen to create some shadow. We do that with normal intubations as well. It also helps. We have the same issue with seeing a monitor at times, again mitigated by those tactics. With our patient population, there's often blood in the airway, which can potentially obscure the lens of the camera, which is why I think direct laryngoscopy is still a very important skill in this environment. There is a different technique to using all video laryngoscopes, and each make in particular and each type of video laryngoscope in particular will have a slightly different technique to get the optimal intubating conditions. And that requires practice and experience, which isn't necessarily the same skill as direct laryngoscopy. And finally, one hopefully unique thing that you shouldn't normally encounter in hospitals is that our equipment is often relatively roughly handled. For example, we may have to throw our bags over a fence to get out of what looks like a decent landing site from the air. Or we may have to, we have to sort of roughly throw our bags out of the aircraft if we're shutting down in a hurry. And obviously expensive, delicate kit may not necessarily be pre-hospital clinician proof. So we need to be aware that our kit may not work as effectively as we'd like when actually we finally get to see it, and be prepared to adjust our plan accordingly. Thank you very much, everybody, for your attention. We're happy to take any questions on this talk that you feel you want to ask us. Thank you.
Thank you very much.